A good day to all of you, and welcome to SG APICS 2020, the first ever completely virtual intensive care conference organized by the Society of Intensive Care Medicine Singapore. In the past few years, we have organized SG NZICS, an annual intensive care conference held in Singapore, with our Australian-New Zealand Intensive Care Society partner. We established a reputation for delivering high-quality content in a fun, safe, and comfortable environment. We made great strides in making our content accessible, achieved progress in areas of accessibility and low middle income delegates with our education grants and awards, and in areas of general equality in intensive care medicine by engaging opinion leaders. As we were gearing up for our largest edition of SG NZICS this year, COVID came into the picture. In the early phase of the pandemic, we anticipated the possibility of global travel restrictions. And with time, it became clear to us that the physical conference would be impossible. We made an early decision to postpone SG NZICS to the disappointment of many people. Now, as healthcare workers in intensive care medicine, we are trained to be innovative, adaptable, and decisive in the face of crisis. And so our team innovated, adapted, and decided to go completely virtual to fill the gap and to continue to engage our loyal followers from around the world. This was the birth of SG NZICS and SG APICS. And so here we are, about 11 months from the onset of the pandemic. COVID-19 is continuing to ravage many healthcare systems, resulting in increased morbidity and mortality, not just from the infection, but also from resource diversion from other medical needs. Intensive care teams around the world are forced to treat large numbers of critically ill patients under terribly difficult circumstances. Along the way, we have lost patients and healthcare workers, and we remember them and honor their sacrifices. Such hot, high-pressure environments are unpleasant and uncomfortable, and it is also the same environment that diamonds are formed, solid, beautiful, and precious, just as the human spirit can be. We are witnessing rapid innovation, and science is running full steam to get us through this dark tunnel as soon as possible. Over the next 2 days, our faculty will be shining light on the latest research and development in both COVID-19 and non-COVID-19 areas. I'm grateful for their willingness to share, as well as for their time. I want to thank the organizing chairperson, Dr. Jensen Ng, and the scientific lead, Dr. Andrew Lee, for their leadership, and also for the rest of the team for their dedication and hard work. Thank you very much. You are indeed the pride of SICM. One of our proudest SG APICS achievement is that we have managed to keep this event totally free for all. I'm grateful to our conference secretariat, Kines, for their confidence in us, as well as to our event sponsors for helping us achieve this. Finally, I thank you, the audience, for joining us today. I hope that you'll find this conference enjoyable, engaging, and effective for your practice. Now, please stay safe, and I hope to welcome you again in person when we get together again in Singapore. Thank you.
Okay, hi, good morning, everyone. We are very excited to have everyone join us at APICS 2020. We have in store for you an exciting lineup of 6 plenaries and 14 tracks with many renowned speakers. We even have speakers coming from across the other side of the world, 12 hours time difference apart, where some of them had specifically even pre-recorded the sessions to join us, to share with us their knowledge, their experience, and their thoughts about the various aspects of critical care medicine and their relation to COVID-19. Some general administrative instructions that I would like to provide. First off, we would please do refer to the program schedule that is on the system to join the tracks. There are a total of 6 plenaries and 14 tracks as mentioned. In addition, we do have exhibition booths that you can visit online. Please do visit them with our various sponsors present. And we also have set up several MCQs for you to actually have a feel and have a trial to take a look and see how much do you know, or how much do we want to find out more about critical care medicine and its relation to COVID-19. So starting off, we will be starting our first plenary session strictly at 9 o'clock. So please stay tuned, and we are looking forward to seeing you. See you.
Go ahead.
Okay, good morning, everyone, again. We are very thankful for everyone joining us early this morning. And to start off, we have our first plenary speaker. Okay, we have Prof. Phua. He is a consultant intensivist and respiratory physician with the fast and chronic programs in Alexandra Hospital and the Division of Respiratory and Critical Care Medicine in National University Hospital. He is the past president of SICM, the deputy chair of the National Intensive Care Unit Repository, the chair of the Asian Ventilation Forum, secretary of the Asian Critical Care Clinical Trials Group, and the chief executive officer of Alexandra Hospital. We are very privileged to have him, and we would like to welcome him to start off this program. Jason, please.
Thanks very much, Andrew. Let me just share screen. Right, morning everyone. Like what Hong Liang said just now in his opening, it's been a really bizarre year, hasn't it? I think many of us still remember the days when we watched in horror as our colleagues, mainly in Wuhan, China, fought so hard to battle COVID-19. And amazingly today, many of our colleagues in the ICUs around the world continue to struggle with the same virus. And I think, you know, if we think about it, many, if not most of us, have at some point or another been tempted to try new therapies, been tempted to try old therapies, been tempted to just do more for our patients in an attempt to improve their outcomes. And in this talk, I'm going to discuss this temptation, whether it's something that we should succumb to, or whether it's something that we should resist, whether it's something that's good or whether it's something that's bad. I'm going to use this very nice graphic from Zeus Wersinger, published in JAMA. I'm going to talk about 4 different points. Firstly, we know that it's the SARS-CoV-2 virus that infects the cells, and I'm going to talk about the off-label drugs that are used to block this virus. Secondly, we know that in early stage COVID-19, there starts to be an inflammatory immune response. Some people call it the cytokine storm, and that's what I'm going to talk about. And thirdly, in the later stages of COVID-19, patients start to develop ARDS, and that's the third issue. And finally, thrombosis, this thing that we've been hearing about so much. So first, off-label drugs. We all watched in quite a bit of amusement as Donald Trump got COVID, right? And this is from the BBC. We know that he took not just dexamethasone, but remdesivir, not just remdesivir, but monoclonal antibodies. And interestingly, he took zinc and vitamin D, and he took melatonin, not to mention aspirin and famotidine. And well, this was apparently for therapy. He, of course, took hydroxychloroquine as well, and that was half a year ago, and obviously it didn't help. And this is his tweets. Taken together, we have a real chance, you know, to be the biggest game changers in the history of medicine. People are dying, move fast, God bless everyone. So this whole thing about hydroxychloroquine, how did it start? If you look back, the original study came from Marseille in the south, France, and this is a really small study. It's a non-randomized clinical trial. It's got like 16 patients who were not given hydroxychloroquine, 14 on hydroxychloroquine, 6 on a combi of hydroxychloroquine and azithromycin. And what the primary outcome wasn't symptoms, wasn't real mortality. It was percentage of patients with PCR positive samples. And well, in this study, the hydroxy and azithro arm had the greatest reduction, followed by hydroxychloroquine, followed by the controls. And the main issue, I think, of this study is that, look at this, there were 14 patients on hydroxychloroquine, 6 on a combi. Importantly, 6 others which were not included in the study. And that makes up like what, 1/3 of the patients on this drug who were excluded. And why were they excluded? They were excluded because 3 went to the ICU, 1 died, 1 was discharged, and 1 stopped the drug due to nausea. And I think most of us would be quite skeptical when we have patients who are excluded due to negative issues. And yet, this was stated in the study that for ethical reasons, and because our first results are so significant and evident, we have to share our findings given the urgent need for an effective drug against SARS-CoV-2. But really, since then, this is a systematic review, and there have been a few of hydroxychloroquine, and this was from Rochester. And it showed that, yes, there is an association with hydroxychloroquine and short-term mortality in, it showed that no, there's no association between hydroxychloroquine and short-term mortality in COVID-19. This was from 9 cohort studies and 1 randomized controlled trial. And these are the big studies. We have studies from Brazil, we have studies from Spain, we have studies from the United States and America, ranging from mild COVID-19 to non-hospitalized adults to using it as post-exposure prophylaxis. And it is now very clear whether you're talking about systematic review of observational studies or randomized controlled trials that it does not work. In fact, it may harm. And why do I say that? This is the recovery study that was just published in the New England. And it actually showed that when used in hospitalized patients, the 28-day mortality is higher. So let's go on a little bit. Let's go on to what's been termed as the cytokine storm. This really hit the news, right? Whether you were talking about mainstream journals or mainstream media or social media, New York Times, the BBC, CNN, evidence grows that inflammation is culprit in severe COVID-19, cytokine storm, and drugs that may calm the storm. And how did it actually start, this whole thing about the cytokine storm? Again, if you look back, one of the main papers that really triggered this excitement was from the United Kingdom. And it's a correspondence published in Lancet Respiratory Medicine. And Dr. Mehta and colleagues, they looked at studies that had come out of China, of Wuhan. And they noticed that the inflammatory markers of many of these patients, they were raised. And there was some association with mortality. And they asked whether or not there's a link between COVID-19 and hemophagocytic lymphohistiocytosis and the cytokine storm. Mind you, this was actually a hypothesis. It wasn't proven. And since then, multiple authors, despite the storm that cooked in a teapot in the media, have revealed this whole thing about the cytokine storm. And how have they done this? This is from UCSF, and they looked at different studies of patients with COVID-19. They looked at the biomarker that's most in keeping with the cytokine storm, and that's IL-6. And they looked at the values, and just look at this on the right-hand side of the screen, severe disease in terms of picograms per milliliter. You're talking something like IL-6 levels of between 7 and 64. You look at the major ARDS studies, the alveoli, the FACT, the SAIL studies, these are pre-COVID-19 clearly. And you look at the hypo-inflammatory or the hyperinflammatory ARDS levels, and you look at the IL-6 numbers being much, by multiple fold higher than what's been reported in COVID-19 ARDS. This is some nice charts that showed that, in fact, when you look at soluble TNFR1 in a HARP2, which is the ARDS cohort that's not COVID-19, the levels are higher than in COVID-19. No difference in the IL-6 levels between COVID-19 and HARP2. And we have more. This is analysis coming out from Amsterdam, where it showed that actually COVID-19 levels, COVID-19 cytokine levels are actually lower than those of sepsis. Just look at this IL-6 COVID-19 levels and sepsis with ARDS COVID-19, non-COVID-19 levels. And this just came out this week. This is from the Lancet Respiratory Medicine, which did a systematic review of patients with COVID-19 from multiple different studies, of the major studies for ARDS, many of them from the ARTSNet studies, as well as major studies in sepsis. And again, look at the number of times the IL-6 levels in non-COVID-19 are higher than in COVID-19. You are talking 1,000-fold, 1,000-fold. Cytokine storm in COVID-19, really? And so meanwhile, before these systematic reviews came out, we all got excited. We talked about IL-6 blockers like tocilizumab, and we saw mortality being reduced in these observational studies. And this is a study from Italy. Look at the nice Kaplan-Meier survival curve, where tocilizumab improved outcomes. This is from the United States. Again, nice Kaplan-Meier survival curves, tocilizumab improved outcomes. But, oh, more studies. This is a systematic review in CID, again, from Amsterdam, tocilizumab improved outcomes. And these are all observational studies. But this, unfortunately, has not been shown in randomized controlled trials. This is the original CoVector trial, actually done by the company that does toci. It hasn't been published yet, but the preliminary results has been released. And we see no difference in mortality, ranging about 20%, 90%, 20%, whether you are given toci or not given toci. But this has been studied, and this has been published in Boston. This is the Boston back-based study. And, well, if you were a high myope, you wouldn't be able to see two different lines in the Kaplan-Meier survival curve. No difference in mechanical ventilation or death, no difference in clinical worsening, no difference in discontinuation of oxygen. So that's tocilizumab and the cytokine storm or the lack thereof. And then we go on to ARDS. We know that COVID-19 causes inflammation, it causes interstitial thickening, it causes increased vascular permeability and edema, it causes ARDS. What we are interested today is whether it causes a different kind of ARDS. Does it cause pseudo-ARDS? When we again go back in time, we wonder, you know, how did it all start? This thing about COVID-19 causing a different kind of ARDS. And this is the original paper by Luciano Gattinoni and his colleagues, where they looked at the first 16 of their patients, and they found that these patients actually had really okay compliance. You look at the numbers here. These are bar charts showing the compliance of the patients, and many of them were above 50 milliliters per cm H2O. And yet, when you look at the right to left shunt fraction, many of them had severe shunt. And so the hypothesis is that it's not the interstitial edema, it's not the alveolar edema, it's not the loss of compliance per se that resulted in severe hypoxemia in COVID-19. It was actually the loss of lung perfusion regulation, the loss of hypoxic pulmonary vasoconstriction. Some people say maybe later on, the thrombosis within the pulmonary vessels. And as a result, diversion, hyperperfusion of gaseous tissue. and this is a statement by Gattinoni and colleagues, such a wide discrepancy is virtually never seen in most forms of ARDS. And we know, yes, it's true. And we've seen pathology reports. There is vascular endothelial damage, there is thrombosis, there is angiogenesis in COVID-19. And as a result, we now hear of two different kinds of phenotypes, the L phenotype, where the elastance is low, which means the compliance is high. There's low VQ ratio, there's low lung weight, there's low lung recruitability. The CT scan shows a little bit of alveolar, interstitial, ground glass appearance, but not much. And then there's the H phenotype, which is what we are more familiar with before COVID-19, with high elastance, low compliance, high shunt, high lung weight, high lung recruitability. And this L and H phenotype has really gone viral. But really, again, really? Eddie Fan, this is an analysis led from Toronto, asked, is a different approach to the management of COVID-19 ARDS truly warranted? And what they did was they looked at the different studies of COVID-19 that had measured compliance. And yes, in certain centers, like those from Italy, which I just described, in Amsterdam, the compliance looked quite decent. But many other centers have not found this decent compliance. Many other centers have found compliance that are as low as what we are usually familiar with in ARDS. In fact, there is a nice analysis in a Blue Journal that looked at non-COVID-19 ARDS patients in the original Lung Safe trial from years back. And they too found that, well, before COVID-19, there was a range of compliance. There were close to 3/4 of patients with the original H phenotype, low compliance. And there were 12% which had the L phenotype, which is the high compliance. So maybe COVID-19 is just like ARDS, which is just like COVID-19. There's a huge range of compliance. It could really be an issue of when you measured the compliance, when the patient presented, what your mechanical ventilator settings were. And this is actually a very nice study by Gattinoni's group, Davide Ciumello in Italy, which was just published this week, which looked at patients, it's about 30 of them with COVID-19, matched to 30 other non-COVID-19 patients with the same PF ratio. And they found that, well, true, maybe COVID-19 patients had a higher respiratory system compliance. Oh, they also found there's 30 patients with COVID-19. They found 30 patients without COVID-19, but with the same compliance. And this time around, again, they found that the COVID-19 patients had more severe hypoxemia. But number one, it's a small study. And number two, again, could it be that we are just measuring patients at different points in time of their disease evolution? And if you look at the study, this is exactly what the doctors, the researchers acknowledge in the paper itself. Regardless, whether the H and the L are real things or actually just part and parcel of good old ARDS, what is of more concern are recommendations taken out of context and management that deviates from usual ARDS guidelines. Some have suggested that we use more liberal tidal volumes, that lower tidal volumes are unnecessary in L phenotype COVID-19 ARDS. The problem is that if you go back all the way to the original ArtsNet study that showed that low tidal volumes were beneficial, they were beneficial across an entire spectrum of ARDS. They were beneficial even as you go lower and lower, where the plateau pressures went down to as low as 20, and mortality still improves. In fact, even in patients without ARDS, and this is a nice Brazilian meta-analysis of non-ARDS trials, tidal volumes, limiting tidal volumes have been shown to be beneficial. And so you worry that because we've seen maybe a certain type of phenotype, that suddenly all of us start to deviate from the original ARDS recommendations. And without the randomized controlled trials to prove this, are we sure that we are not going to cause harm? Let me go on to thrombosis. And this is from Reuters. Alarmed as COVID-19 patients' blood thicker, New York doctors try new treatments. This was just published. A poll in, actually this week, the New England. And the question was, would you continue prophylactic anticoagulation for COVID-19 patients and discontinue at hospital discharge? Or would you go up on your intermediate, on your dose of anticoagulation and then continue anticoagulation after discharge? And amazingly, more clinicians would do the latter than the former. So how did it all start? Well, it's all these studies, right? All from Europe, from America, from Asia. They have shown, and this is a guideline from CHESS, 14 studies, that the prevalence of VTE ranged from 1 to 54%, a huge, huge range. But the 54% is scary in ICU patients. Nice meta-analysis from Zhengzhou, China, of all these studies, and it showed that, wow, 8% of published studies patients have pulmonary embolism. Of those who were investigated for pulmonary embolism, 28%. Of those in ICU, 19%. Those not in ICU, 9%. High numbers, high numbers. And so we now then have guidelines like this. This is from the Anticoagulation Forum that suggested that we increase the dose of VT prophylaxis to double. So you usually give enoxaparin once a day, now you give twice a day. And of course, these guidelines would all acknowledge that they are largely based on expert opinion. We have protocols in different centers that do this, enoxaparin 0.5 mg per kg, 12 hourly. But again, really, where did it all start actually? Where did it all start? This is the classic paper from China that sort of started it all. What they found was that in patients who were given heparin, and these are the blue lines, their mortality were lower if something called the sepsis-induced coagulopathy score was higher, i.e. the platelets were more crappy, the INR was deranged, etc. And again, they found that the mortality difference was more significant if the D-dimers exceeded 3, 6 times the upper limit of normal. Again, when you look at the study, we really got to be careful because the definition of heparin anticoagulation in this study was that they were given low molecular heparin for more than 7 days. I.e., if you were given it for less than 7 days, it's not counted. And you wonder whether this could have led to an immortal time bias. There was also no adjustment for confounders. This is from John Louis Vincent's group, recently published again in SICM, looked at 40 patients who went to have a CTPA. And they found that, yes, maybe the minority of people who were given high-intensity heparin had PE, whereas more people who were given standard dose heparin did not have PE, had PE. So there's some signals there, but all very small studies, no randomized controlled trials. Also, a possibility that overdoing things may actually worsen matters. Well, this is a very nice study from France that looked at 92 patients who were all on prophylactic or therapeutic anticoagulation. That's a practice in the ICU. And they found that despite this, 40% of their patients had thrombotic events. Well, you would say, okay, let's now all give them even higher doses of anticoagulation, but look at this. 1 in 5 of them had hemorrhagic events, some of them significant. And out of the 1 in 5, half of them actually never developed thrombosis. And yet they had hemorrhage. So it's a balance, right? Would you really want, without the evidence, to increase your doses of prophylactic anticoagulation? Some guidelines, like the Anticoagulation Forum or the ISTH, would say yes, but most guidelines, more guidelines would say no. This is from NIH, from JACC, and from CHEST. So I've reviewed very quickly 4 different issues, and I just want to quickly go on to why do we do this? Why are we also tempted? I think it's clear. It's because this is yesterday, 41 million people have gotten COVID-19, 1.1 million at least, and this is not counting those that are not diagnosed, right, have died from COVID-19. There is a crisis. We see an opportunity from this crisis. The patients want something better for them. The clinicians want to help these patients. The researchers see an opportunity for research, for publications, for their H index. The policymakers, some of them in the United States, sees an opportunity to say, I'm doing more for my population. And so we have this. We have 66,000 papers on PubMed. If you Google COVID-19 2 days ago, we have close to 10,000 preprints, and we have this information overload, and we're all struggling, right? And so when people try to phenotype more, COVID-19, H&L phenotype, there is a risk. There's a risk that we start to see what we think people have told us that it exists, like the H&L phenotype, and then it becomes more and more clear in our mind, even though it may not be there. And when it's not there, we say, no, this cannot be COVID-19. So this is called the Bader-Meinhof and the no true Scotsman fallacy. We start to tailor management, even though it may not be evidence-based, based on randomized controlled trials. We start to want to treat more. And this is a paper that some of my colleagues did from the Asian Critical Clinical Care Trials group. And this was earlier on in the pandemic. And we said during that time that these various therapies are being studied, and they have to be studied, and we should not plunge. But yet we have politicians saying that we have no time. Geez, let's take a couple of years, test it out. If it works, that would be great. It doesn't kill people. You know what do you have to lose? Well, mind you, I'm not saying that we always have to go by randomized controlled trials, because the Cochrane analysis has shown that sometimes observational studies are as good as randomized controlled trials. But what I'm saying is that when we read observational studies, we have to be careful about the potential biases, and there are many. And we all know all of this, right? Prevalent user, incomplete follow-up, channeling, confounding, reporting attrition, etc., etc. And whatever the observational studies have shown, the randomized controlled trials, many of them have not shown anything much. This is out in a preprint. This is Solidarity. It's shown that remdesivir, hydroxychloroquine, lopinavir, ritonavir, interferon, they do not save lives. At least as of now, they do not save lives. Look at the Kaplan-Meier survival curves. In fact, even dexamethasone, we think that it saves lives, right? But this is from the recovery study. If you use dexamethasone early in patients without hypoxemia, there is a risk that you may harm. Look at the rate ratio, 1.19. My point is, you got to be careful. You got to choose your patients wisely. You got to look at the randomized controlled trials and not be tempted to do more. What do you have to lose? Well, you can harm your patients. And what should you do? You should read the real papers, really the real papers, the journals, and not just the abstracts, the methods, the results, the limitations. You can distract your team from the real stuff if we all start to do things that are not evidence-based. So can we think about making good usual care good and usual? Good infection prevention, good mechanical ventilation, good anticoagulation, good insulin protocols, etc., etc. You can deprive other patients of the truth. Why? Because you have stopped randomizing patients into trials. you can, if you can, join studies and increase the evidence base that we can all work on. And so I've run through very quickly 4 different issues: off-label drugs, cytokine storm, ARDS, and thrombosis. And my point is that there's a lot of temptation to do more during pandemics. This is just one. I'm sure there'll be more in the future. And really, this is an appeal to everyone not to succumb to that temptation. Thank you.
Okay, thank you so much, Jason. I think that was really inspiring. We've learned really a lot about how sometimes we may need to control our desire and temptation in the haste of wanting to do more in the face of the unknowns. Maybe one of the questions that's come up is about the time course. I think you've mentioned quite a bit about how the unlike conventional ARDS, even among within the time course of COVID-19 patients, they sometimes do have changes in the time course of their management, in the time course of the disease. So how would you advise us at this stage? Because when we talk about the need, people desire to want to keep giving some form of therapies and the likes. Do you think that at this stage, would a conventional evidence-based medicine be much more desired than the temptation to just personalize it straight away?
Absolutely, absolutely. The dexamethasone story is a very good example of time course, right? If you look at the recovery study, again, if you give it too early, you actually cause harm. So I think time course is important, but time course based on gut feel I don't think is right. I think time course based on evidence is important, like what the recovery study has shown us. Yes, give dexamethasone by all means if the patient is starting to deteriorate, getting hypoxemic, going into ARDS. But no, do not give it too early. In fact, you can say the same for convalescent plasma. You can say the same for monoclonal antibodies, right? When should we give them? Is it during the early or late in the illness? And I'm pretty convinced that when the studies come out, they will show that certain periods are better. The problem is that the studies are not out yet. And it is not safe, I think, in my view, to go by what we think is a physiology and then adjust the time course. So yes, go by time course, but go by time course based on evidence.
Okay, and one other question, Jason, was that I think you were mentioning quite a bit about the importance of evidence-based medicine and conventional therapy. In this current setting, how would our application of the evidence-based medicine on conventional ARDS therapy be or would override the need for going into personalized based medicine, given your L and H phenotypes that you were describing just now?
Yeah, you know, I am not a convert at all. I believe that there is a H and an L phenotype. I do. But I also believe that there's a H and an L phenotype, even in non-COVID-19 ARDS. Maybe there's more in COVID-19, I don't know. The reason I'm not a convert is I'm not convinced that doing mechanical ventilation differently will improve outcomes because there's completely no evidence right now. So just because there's a different phenotype, we are tempted to personalize medicines, but show me the evidence that personalized medicine does improve outcomes. I haven't seen it yet. So I would say that at this point in time, it's safer to go by what we are more comfortable with: low tidal volumes, a decent amount of PEEP, prone ventilation for more hypoxemic patients. Those are for sure. Going up on the tidal volumes because we think that the compliance is okay, I think that's going into the danger of into the territory of dangerous territory.
Okay, thank you very much, Jason. We really appreciate the words of wisdom and pearls of advice. Thank you so much. And I think we all want to thank Jason for his time. We've been very privileged. So I think just to end off this plenary session, we just like to remind everyone that some of the basic administrative instructions that we mentioned earlier. The program is actually on the program schedule. So we subsequently after this, we do have the rest of the 14 tracks and the other plenaries. You can access them through there. In the meantime, please do visit the exhibitors booth. You can try out the MCQs, see whether you are aware of some of the answers. And if not, the next session will start at 9:40. Okay. If there's anything, please do reach out to us. And anytime, We thank you once again. We just want to thank you so much for your time spent with us this Saturday and Sunday. Thank you, everyone.